coming to the classification of aortic dissection or acute aortic syndrome. The most commonly used classification is Stanford and another one is DNB. Coming to DNB classification, there are three types in DNB. The type 1 is, it involves the ascending as well as the descending aorta, which is the most commonest type, happens in about 60% of the patient. Type 2, it involves only the ascending aorta. That happens in, the incidence is around 10 to 15% of the patient. And type 3 is, it involves only the descending aorta and it happens in 25 to 30% of the patient. And here there is again a subdivision 3A and 3B. 3A is above the diaphragm and 3B is below the diaphragm. This is DNB classification. But Stanford classification is very simple. There is only two types. One is A, which is proximal, which involves the ascending aorta irrespectively whether it involves the descending or not. There will be ascending aortic dissection, but descending may or may not be there in type A. In type B, there is only the descending aorta involvement. This is Stanford classification, type A and type B. Now coming to Stevenson's classification, here you have 5 classes. Class 1 is nothing but a classic dissection with true and false lumen. Class 2 is intramural hematoma. Here you can see the intramural hematoma. Class 3 is a subtle dissection without hematoma. A small dissection is seen without a hematoma. That is class 3. And class 4 is penetrating atherosclerotic aortic ulcer. And finally, class 5 is a traumatic or iatrogenic dissection. This is Stevenson's classification. Now coming to the functional classification by Penn. Here you look at the symptomatology of or the presentation of aortic syndrome. Class A is uncomplicated, which means absence of any ischemia. Class B, which is called complicated. Here B is for branch vessel malperfusion. The vessels which arises from the aorta are having some regional ischemia. Class C is more dangerous. It is more complicated and C stands for cardiovascular collapse with generalized ischemia due to circulatory shock. So, A is uncomplicated, B is branch vessel malperfusion and C is cardiovascular collapse. This is functional classification by Penn, and there is a class B and C which includes both branch vessel malperfusion as well as circulatory collapse. Now coming to another classification called TEM, which is the type, entry and malperfusion. This was done by Severs and et al. In the type, he had one more addition to the Stanford classification as non-A and non-B, and entry is, he divided into 4 subtypes. 0 means the primary entry tear, the intimal flap is not visible. 1 is if happens in the ascending aorta, 2 is if it happens in the arch, and 3 is if happens in the descending aorta. So, it can be E0, E1, E2 and E3. Coming to M, which is the malperfusion. 0 is there is no malperfusion. 1 is if coronary arteries are involved. 2 is supraaortic vessels are involved. And 3 is visceral, renal or lower extremity vessel is involved. So, you have M0, M1, M2 and M3. What is this non-A and non-B dissection? You have 2 types here, descending and the arch type. The dissection is just distal to the left subclavian artery. That is the descending type. Another one is called the arch type. Here the dissection is located in the arch between the left subclavian and the innominate artery. That is non-A and non-B. Now coming to the classification based on the timing of presentation. It can be hyperacute, where the symptom onset and it is less than 24 hours. Acute is between 2 to 7 days. Subacute is 8 to 30 days. And chronic, it is greater than 30 days. Usually, it is very acute and you have to treat the patient immediately.